Hello everyone, good evening. Good evening. Welcome to the session. So today we will be discussing the questions from July 2025 exam that came for the FMGE exam. So I'm very happy to discuss these questions as such. It was much predicted exam as such with a very good high strike rate of 97% from our classes as well. Majority of the questions were much predicted. जो आना ही था वही question आया है इस बार और बहुत important most predicted areas had come, all of them from the class itself. So we'll be discussing the questions one by one. Along with that, I'll be showing you the key details and points right from the class notes itself. All right, and let's start the session. Okay, let's go through the questions one by one. About this exam, I would say there were nearly about 30 questions, nearly 35 to 37 questions had come right from ObGyn itself. And though the questions were easy, some of the questions, students told that the questions were slightly formed in a tricky manner. They were finding it slightly difficult to read through the question, maybe understand the language of it. Those are some of the concerns that were raised as such, and some of the options were even tricky. Yes, let's go through the questions one by one. So this is the first question. A 22-year-old woman presents with lower abdominal pain. There is a mobile, non-tender ethnic cell mass which is noted. Ultrasound shows that complex ovarian mass with echogenic foci, calcification, and there is shadows also suggestive of bone and teeth. Yes, this is a very typical image as such. This presentation where you are getting this ethnic cell mass with calcification, bone, teeth, hair, cartilage, what will you think about? You will think about dermoid cyst. And in dermoid cyst, it's also known as mature cystic teratoma. So dermoid or mature cystic teratoma, again, this is from class notes itself. So mature cystic teratoma, you have, this is the most common germ cell tumor to undergo torsion, most common ovarian tumor to undergo torsion, most common ovarian tumor in reproductive age group and pregnancy. You have these layers from ectoderm, endoderm, mesoderm, due to which you have variety of cells. Whenever you have an image with teeth, hair, cartilage, bone, mucinous fluid, all those things, a variety of things, think about your dermoid cyst. Sometimes there can be cancer arising from dermoid. It is usually squamous cell cancer and they arise from Rokitansky protuberance. Yes, this is a very typical image of dermoid cyst, also known as mature cystic teratoma. Let's have a look at the next question. A 26-year-old primigravida delivers vaginally at term. Soon after delivery of the placenta, she develops severe postpartum hemorrhage and abdominal pain. There is a mass protruding into the vagina and uterus is not palpable. And they had given this image. Yes, what are they showing you? Mismanagement of third stage of labor is done. The uterus itself can invert and come outside. This is typical of uterine inversion. Yes, uterine inversion, which is due to mismanagement of third stage of labor. Immediately, the patient goes into shock and the uterus comes out through the vagina. The first shock the patient experiences is neurogenic shock. Due to the stretching of the nerves, later on, the patient starts bleeding. Even there can be hemorrhagic shock. First shock is neurogenic shock, but the cause for death is due to hemorrhagic shock. What will you do? Do not try to remove the placenta again. You're going to immediately reposition the uterus. In this question, already they had given that placenta is after the delivery of placenta. If you see that placenta is still attached, with that attached placenta itself, you have to reposition the uterus. Then you're going to give oxytocin so as to contract the uterus. Once uterus is contracted, then you go for removal of the placenta. Yes, this is uterine inversion. Again, a very much predicted and important topic as such. So the next question is on shoulder dystocia. Even in the previous exam as well, there was one question on shoulder dystocia. Again, a predicted area as is the second time in the consecutive exam, they are repeating those topics. Those exact question might not come, but please note those areas get often repeated. That's why we say always focus on this previous year topics as well, which is important. Yes, previously the question was what is the head to shoulder delivery time in shoulder dystocia, which is more than or equal to 60 seconds. This time they had asked you about how to manage a shoulder dystocia. Let's go through the algorithm of shoulder dystocia again from the class note itself. The first and foremost is to call for help. Then you put the patient in Roberts maneuver. Make Roberts look like this. You have to flex and abduct the leg. then you are going to give suprapubic pressure. So the first thing, flexion and abduction, that is McRoberts maneuver, which is the answer to this question, followed by suprapubic pressure. Both these are considered as first line maneuvers. If you fail to deliver the shoulder with this technique, then you go ahead with internal maneuvers. Among internal maneuvers, you have internal rotational maneuvers, also delivery of posterior arm. If at all you have to choose between this, I always number and teach you this. If the suprapubic pressure does not work and you have to choose between these two options, give preference for internal rotation maneuvers. Examples are wood corkscrew maneuver and Rubin's 2 maneuver. If still the shoulder does not get delivered, next you proceed with delivery of posterior arm. Still the baby is not delivered, you position the patient in all four position, which looks like this. This is all four position or Gaskin's maneuver. Still the delivery is not happening. You can either repeat all these maneuvers or proceed with destructive maneuvers. Among the destructive maneuvers, you have cleidotomy. Cleidotomy means cutting the clavicle. You have symphysiotomy, that means cutting the pubic symphysis, and you have Zavanelli's maneuver. In Zavanelli's maneuver, you are going to vaginally push the baby's head back into pelvis. Then you will proceed with cesarean section. Yes. So yes, right from this algorithm, which is very important from shoulder dystocia, this question had come. And this was the question again that came in last time's exam. Shoulder dystocia is a very much important topic that can again be repeated. So students who are preparing for the next exam as well, you have to focus on the complications associated with GDM, shoulder dystocia, macrosomia, all those things are very important. And what are the congenital anomalies associated with diabetes in pregnancy? That complication aspect of diabetes is very, very important. Next time, they can even ask you this as an image-based question as well. Here, the correct answer is McRoberts maneuver. Yes, let's move to the next question as such. What is the purpose of this maneuver? What is being shown over this in this image? Yes. Again, this is yet another question we had discussed in the class session as such. So this, what is shown over here, this is Ridgen's maneuver. So Ridgen's maneuver, you flex the head so as to cause a control extension, and along with that, you give a good perineal support. If the baby just delivers by extension, there can be a tear extending towards the urethra. You don't want that to happen. So you're going to slightly flex the head, giving adequate perineal support. What will this do? This is basically to prevent the perineal tear. Yes. Again, we had discussed the WHO recommendations to prevent the perineal tear. Is episiotomy routinely required? Episiotomy should not be run routinely to prevent perineal tear. Only if it is indicated, you have to give an episiotomy, such as patient has shoulder dystocia, or patient there is macrosomia, you are planning to put in an instrument such as forceps or vacuum. So if there is any indication, you give episiotomy, or else it is not indicated. Often this comes as an all except question. All other points, that is delivery, maintaining the head in flexion, giving adequate perineal support, giving warm compression to perineum, and even slow delivery in between contractions. These are the 4 key points given by WHO to prevent perineal tear. And the initial 2 points, that is maintaining flexion and perineal support, is shown over here as well. This is the Ridgen's maneuver. Yes, let's come back to the question. So yes, the correct answer is to decrease the perineal tear, perineal trauma or perineal tear during the time of delivery. Yes, let's move to the next question. So this was again a topic which is related to the early pregnancy complication. A 28-year-old woman presents with mild lower abdominal pain. Urine pregnancy test is positive. You see that ultrasound is done. There is nothing in the ultrasound as such. Beta HCG is done for follow-up. According to the standard protocol, what is the recommendation for repeating beta HCG levels? Yes. Again, what is this condition? Let's go back to the class notes as such. What is this condition? If you see that beta HCG or UPT is positive, you can't find the pregnancy where exactly it is. This is pregnancy of unknown location. Whenever you have that scenario, what do? You are going to repeat the beta HCG in 48 hours. If you repeat in 48 hours, if you see that there is doubling of HCG, that is associated with intrauterine pregnancy. If you see a fall in HCG, that is associated with abortion. Whereas in ectopic, you get a prolonged doubling time. This was actually a previous NEET question. And nowadays, please note, they are asking you so many questions from previous NEET exam, from the INI exams as well. That's why when we cover all these areas, this paper was much of a predicted question paper, as so many areas have been repeated like that. So just because you are preparing for FMG or any one exam, I would say don't confine yourself to that exam alone. All these topics are important, and nowadays, at least for the past 2 years, 2 to 3 years, we have been observing that so many questions, at least from the OBG exams, at least I would say minimum. I would say it's for all, but at least for OBG exams, so many questions are coming up from the INA exam, from NEET exam. So do cover them. Now, especially the batch who is preparing for the next exam, for the Jan session, you have adequate time. Try to cover at least 3 to 5 years of NEET PG papers and 3 years of INI as well. That something which is quite doable at this point of time, and it's going to definitely help you guys. Yes. So go through those questions, go through those areas as such. Never just read one question and just confine yourself to that area. Read that topic as well. Yes. So again, this was much of a predicted question as such. What do? You are going to repeat the beta HCG in how many hours? After 48 hours. This condition is pregnancy of unknown location. Basically means UTP is positive, ultrasound doesn't show you anything. So you don't know the location. Yes, it is pregnancy of unknown location. You're going to repeat the beta HCG levels. So the next question was on CTG. Yes, cardiotocography. And again, in the last session as well, there was one question on CTG. Even this time, they provided a question on CTG as such. It's very important. Even they can give you an image of this as well, make you identify what type of deceleration is given. Let's go through those details. Variable decelerations, they are associated with cord compression. Especially in CTG, you have to know 3 types of deceleration to identify and where you see these types of decelerations. Let's go through them one by one. The first one that you are seeing here, this is early deceleration. What is meant by early deceleration? Early deceleration, the onset of deceleration corresponds to onset of contraction. The peak of the contraction corresponds to nadir, or the bottommost point of deceleration, and the ending of contraction corresponds to the recovery of deceleration. In simple words, if I tell you, both of them look like mirror images. Just like mirror image, it is early deceleration. जैसे आपका deceleration contraction start होता है, उसी समय आपका deceleration भी start हो रहा है. जब आपका contraction खत्म होता है, उसी समय में deceleration भी आपका बंद हो रहा है. So same, it is just like a mirror image. Think about early deceleration. Whereas late deceleration, late as the name suggests, it is slightly late. आपका contraction तो आ गया है, deceleration थोड़ा सा late है. Your contraction has started over here. The deceleration starts after some time. The contraction has peaked, and after some time, the deceleration is at its nadir, and contraction has ended, and finally, afterwards, the deceleration is ending. So this is basically associated with uteroplacental insufficiency. Yes, the last one is variable deceleration. Variable deceleration, as the name suggests, there is no relation. Contraction अपने time से आएंगे और आपका deceleration उसके हिसाब से आएंगे. There is no relation between the contraction as well as deceleration. That is variable deceleration. And this variable deceleration is associated with cord compression. It is associated with cord compression. Just a mnemonic for you to remember this whenever you are taking the delivery as well. What is the first part that comes out, or the thing that comes out early? Yes, that is the head, right? So early deceleration, head compression. What is the thing that comes out last? आपको बहुत wait करना पड़ता है इसको आने के लिए. What's the last thing that comes out? Placenta, right? So late connect with placenta. Late deceleration, uteroplacental insufficiency. And what is that structure which keeps on moving? There is no fixed relation. It keeps on varying. It is umbilical cord. Umbilical cord keeps on moving in the amniotic fluid. So think about that. So variable deceleration is cord, related to cord compression. Yes, hope you will never forget this as well. You can use that mnemonic to remember that. Is very important. Again, this question will get repeated. They will show you various types of CTGs as such and make you identify either the deceleration directly, or they can ask you an applied question asking you that which deceleration is associated with, which condition is associated with this deceleration. Yes. Next, even you have the sinusoidal pattern. Sinusoidal pattern looks like this. There is a sine wave kind of pattern. And the sinusoidal pattern is associated with fetal anemia. The sinusoidal pattern is associated with fetal anemia. Can you tell me few conditions where you can see fetal anemia, such as Rh isoimmunization? In Rh isoimmunization or infections such as parvovirus or even Vasa previa. Vasa previa, which is associated with bleeding, it's the fetal blood that goes out. The baby can have anemia and even rapid severe fetal distress can happen in the patients. So these are the conditions where you get this fetal anemia and sinusoidal pattern. Yes, the next question was on partogram. Whenever I teach partogram in the session, students often ask, "Ma'am, इतना आएंगे क्या?" मतलब partogram पूछते हैं FMGE में. This is one question often they ask, and yes, which आता है इस बार तो partogram directly they give a beautiful image-based question on this as such. And this is again the class note from partogram. Let's discuss about the question first, and I'll teach you in detail about the partogram. So, a primary gravida has presented and she was 4 centimeter dilated initially. After 4 hours, the cervical dilation progressed to only 6 centimeters with uterine contraction recorded as 3 in 10 minutes. Fetal heart rate is normal. Partogram shows that the graph is approaching the alert line. This much information was not completely given in the question. Some of it you had to even derive from the image as such. See, if you get a partogram like this, what is being shown over here? You have 2 prefix lines. These lines are, this is the alert line. The next line is action line. Alert line is drawn, is a pre-drawn line, which is at the rate of 1 centimeter per hour. If suppose a patient is progressing 1 centimeter per hour, it will look something like this. It will fall on this alert line. If suppose a patient progresses faster than this, what will happen? The plotting will be to the left of alert line. So any plotting to the left of alert line is going to be normal. Anything to the right of alert line is abnormal. So let me first just briefly teach you about partogram, and I will make you understand what the question exactly was given as such. See, so if I just mark in this image as such, so this is the alert line. This is the action line. In this patient, you can see a plotting which is there to the left of alert line, and that is completely normal. Anything to the left of the alert line means she is progressing more than 1 centimeter per hour. We are very happy with that. Anything that crosses alert line goes to the right of alert line. That means she is progressing less than 1 centimeter per hour. Again, from labor abnormalities, what did I teach you? Anything where in the active phase, when the progress is less than 1 centimeter per hour, it is protracted active phase. What will you do for that? You are going to do artificial rupture of membrane or give the patient oxytocin accordingly. If you have to choose one, we prefer ARM first, especially considering this patient has adequate good contraction. What will you do? You are going to do ARM or artificial rupture of membrane. We had even discussed some model scenarios. Yes, this was the image that we discussed in the class as well. If you have something which is going to the left of alert line, it is going to pass means you are going to think of a slow progress happening less than 1 centimeter per hour. What will you do for the patient? ARM and oxytocin. Here patient is already getting good contractions. You will initially proceed with ARM. Usually we do ARM first, then oxytocin. Let's discuss another scenario. If the next time they give you a graph like this, where you see that the dilation is constant, it is not changing. The distance between the alert line and action line is nearly 4 hours. For 4 hours, it is same means you are dealing with arrest of dilation. If you have same cervical dilation in a patient who has good contraction, even after doing artificial rupture of membrane also, if the dilation is same for a period of 4 hours in active labor, you are going to call it as arrest of dilation. How to know whether it is arrest of dilation or descent? Dilation will be marked with X, whereas descent will be marked with 0 or an O. What are you seeing in this image? This is arrest of dilation, whereas the second one, this is arrest of descent. If you have arrest, what will you do in that scenario? You are going to proceed with cesarean section. So then the next exam, if they show you this graph and ask you what will you do, please mark it as cesarean. Don't by heart any form of partograms as such. If I plot 100 partogram for 100 different women, it will look slightly different for each and every woman. Don't by heart the partogram as such. Just make your theory in the topic of labor abnormalities very thorough. What is meant by protracted active phase? What to do if the rate of dilation is less than 1 centimeter per hour? Less than 1 centimeter per hour in active phase, you will do initially ARM followed by oxytocin. Arrest of dilation is there. You are going to proceed with cesarean section. Yes. So that is how you interpret the partogram as such. Apart from this, in the partogram, what you are seeing here, these are the contractions. How to read this part as such. Again, the contractions are plotted as dotted box. Let me just show you the exact area. Yes. It is plotted as dotted box, line box, and densely shaded box. Dotted box means the contraction is lasting less than 20 seconds. Line box 20 to 40 seconds. Densely shaded boxes more than 40 seconds. So in the partogram, if they show you this aspect, can you interpret this for me here? What is shown here? There are 5 contractions. 1, 2, 3, 4, 5. 5 contractions lasting more than 40 seconds. Whereas the first one, if you see, is 1, 2, 3, 4. There are 4 contractions lasting 20 to 40 seconds. If suppose I make a box like this with dotted box, you will say 1 contraction lasting less than 20 seconds. Dotted box. Yes, this is how you read the contraction aspect as well. Even on the top, they can give you this amniotic fluid findings. Here it is C is marked. C means amniotic fluid is clear. If suppose in the next scenario, they give something else, they give you B. B means B is for blood stained. If they give you M, M is for meconium stained amniotic fluid. Yes. C means clear, B means blood stain, and M is for meconium stained amniotic fluid. If rupture of membrane is not done, they will give it as I. That means amniotic membrane is intact. It is intact. Yes. So let's come back to our question. Now that you are aware of the basics of this partogram, let's come back to the question. What are you seeing over here? See, each of these large boxes denote 1 hour. 2 small boxes. It is basically 1 large box. This is 1 hour. So 5, 6, 7, 8, 9. You see that from 4 centimeter, she went till 6 centimeter. Over how many hours? She progressed over 4 hours. Over 4 hours, she progressed. How do you know it is 4 hours from the graph? This is 5, 6, 7, 8, 9. Yes, so it is nearly 4 hours. Also, she is that same that dilatation, which is less than 1 centimeter per hour. She only progressed 2 centimeter of 4 hours. This is protracted active phase. We are going to do ARM followed by oxytocin. Yes, that's the answer to the question. If suppose the next time they give ARM, amniotomy or ARM separately as well, you are going to choose ARM first in such scenarios. All right, let's go to the next question. Any doubts or questions? Can feel free. Yes. Okay. Any questions or doubt that you can please post in the exam as well, in the comment box as well. Sorry, I was just going through the comments here. First option was expected management. Another option was no intervention is required. In this scenario, we won't do just expected management here. Protracted active phase is there, you are going to act for the patient. Less than 1 centimeter is there, you are going to act for the patient as such. You are not going to just leave the patient alone at that point of time. Not intervention is not the answer. If you had got a clinical scenario which you have prolonged latent phase means less as per this partogram, it is till 4 centimeter, that is less than 4 centimeter, whereas as per the current WHO, it is less than 5 centimeter as such. So if you have a patient in prolonged latent phase, latent, as I always say, latent, patient is latent, you are also latent and lazy. Eat 5-star and do nothing. If you see in latent phase as such, you are not going to do anything for the patient. Yes, feel free to post more questions or queries if you have in the comment section as well. Let's have a look at the next question. What is meant by code testing in the context of cervical cancer screening? What is meant by code testing? Simple, direct question. You are testing pap smear, that is cytology, along with HPV DNA testing is done together. Among this, which cytology is given over here? Liquid-based cytology. Yes, these are the different screening methods that we always discuss. You have cytology, that is pap smear, and liquid-based cytology. We have HPV DNA testing and visual inspection methods. Among this, the best test or the most sensitive test as such is HPV DNA testing, best. Whereas the most commonly done test is cytology. If you have a low resource patient where cost is an issue, the cheapest test that you can do is visual inspection methods. Whenever you combine this HPV DNA plus cytology, that is known as co-testing. Yes, cytology plus HPV DNA, that is known as co-testing. Mostly we combine pap smear, even you can do liquid-based cytology as well. Few more points about these pap smear. In pap smear, we use these instruments. Even this comes as image-based questions frequently. What you are appreciating over here, the one with the bifid tip, this is the Ayer's spatula. Whereas the second brush, this is the endocervical brush. You take the smear initially from the ectocervix, that is with Ayer's spatula, you rotate it through 360 degree. Then you take a inside smear, that is from the endocervix, that is through the endocervical brush, rotate it through 180 degree. You are going to smear it, then you will put it in the Coplin's jar. And what is the fixative that is present here? Fixative is 95% ethanol. This was another question that came from this exam. There were actually 2 questions that came just from this screening aspect as such. This was the first question again, and soon sometime I will show you this. What is the fixative is used? That is used 95% ethanol. Whichever be the exam you go, cervical cancer, cervical screening are must know. Definitely you will get at least 2 or maybe more than 2 questions from the topic of cervical cancer, cervical screening. That is must know as such. Yes, even for the students for the next exam, have a note. This is like, yeah, INI cervical screening is must know for you guys, as well as cervical cancer is a must know topic as such. Let's go to the next question. Yes, it is from the early pregnancy signs as such. An image is shown as shown over here. What is the sign that is being elicited in this? Yes, you can see that there is a finger which is approximating the abdominal hand at the level of isthmus. And you can approximate both these hands because isthmus is soft. What is the sign that is shown over here? This is the Hagar sign. This is the Hagar sign. Now, some of the students were asking me doubt, ma'am, here it was marked in blue. And isn't blue color what you see in Chadwick sign? Chadwick sign or the Jacquemus sign, which is there, where you get these blue discoloration assets that is present at the level of cervix. Here they have just represented it. They have just shown you the level of isthmus. This is simply your Hagar sign. Yes, again, this is from the class note itself. This is showing you the Hagar sign where you can compress the isthmus. Let's go through all the other signs. This question again, ये तो आना ही आना है, whatever be the exam paper. In the last time FMGE exam, 2 questions came from early pregnancy signs, and this is must know again. This time, this Hagar sign came as an image-based question. Yes, isthmus softening is Hagar sign, which is shown in the image. Cervical softening is Goodell sign. Pulsation fell through vaginal fornix is Osiander's sign. Bluish discoloration of ectocervix, Chadwick sign. Even vagina, if you see as blue, it is Chadwick sign. Yes, this is cervix and vagina, which appears externally as blue. Whereas in this, you are palpating at the level of isthmus. Rhythmic contraction. When you keep your palm or hand over the uterus, you feel that contraction, that is Palmer's sign. Due to the lateral implantation of the conceptus, you get an asymmetrical growth of uterus, that is Piscacic sign. The initial bleed that you get during the time of implantation bleed is known as Hartmann's sign. Yes, this is very, 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 very important must know topic as such. All these early pregnancy signs. When do you get quickening? Quickening is the initial movement that is appreciated. This is a second trimester sign. This happens in T2. Where do you get ballotment? Ballotment again in the second trimester. When does the patient starts appreciating lightening? Lightening, also known as welcome sign. Once the fetal head descends down into pelvis, the mother has a sense of relief. When does that happen? In the 3rd trimester. Yes, in the 3rd trimester as such. All right, these are the times that you get. About the results, maybe usually that happens after nearly 2 weeks, dear. So 1 week is already over. So in a couple of weeks, you can expect the results as such. But as of now, let's go through the discussion. Don't overemphasize or think about the results as such. As of now, try to enjoy your time until the results are coming. And yes, let's discuss the questions as well. So maybe in a couple of weeks, you can expect it. All right, let's have a look at the next question on postpartum hemorrhage. In this question, patient has been given uterotonics, including oxytocin, and uterine massage is also done. And the vitals are borderline stable. They are asking you, what will you do next? This is the algorithm of management of PPH, postpartum hemorrhage. Let's go through the notes as such. What do you do? Whenever a patient has PPH, first and foremost that you're going to do is call for help. First is call for help. Next, you are going to stabilize the patient. How do you stabilize? The question might give you to put IV cannula, take out the blood, start fluids, give the patient blood. Once it is available, we initially give O negative blood. Then we start massaging the uterus. The third thing is massage the uterus, empty the bladder. Then you will proceed with the drugs. All the uterotonics, oxytocin, ergometrin, carboprost, misoprost, all these are the uterotonics in the order. If this still fails, what will you do next? Next is mechanical method, and question has come from this. Often they block you at one of the point in this algorithm and they will ask you, what will you do next for the patient? Yes, if oxytocin, all those medical measures have failed, you're going to next proceed with mechanical measures. Mechanical measures such as bimanual compression or balloon tamponade. As in the question, the step is balloon tamponade. If still that fails, what is the next thing that you're going to do for the patient? You are going to proceed with uterine compression sutures such as Beelin suture. Question was, what is the first surgical procedure? If this has failed, still you will not directly shift to surgery. Even if the surgical step was asked in the question, still what are you going to do? You are going to initially insert the balloon tamponade. If balloon tamponade is given in the options, you have to go ahead with balloon tamponade here. Then comes the definitive surgical steps as such: uterine compression sutures, stepwise revascularization, and hysterectomy for the patient in the order. If balloon tamponade is in the option, the next is going to be balloon tamponade. It is going to be balloon tamponade first, then you will go ahead with the next step as such. Even if the next surgical step is given, next thing among this is going to be balloon tamponade. Only then you are going to proceed with each of, because it is a much easier step as such. Then you will proceed with the definitive surgical steps such as the Beelin sutures, stepwise devascularization, and last one is hysterectomy for the patient. Yes. Let's move to the next question. A 25-year-old female has presented with infertility and there is unicornuate uterus. There is defective formation of fusion of which embryological structure is associated. All these anomalies, they comes under Mullerian anomalies. Mullerian duct or Mullerian duct is also known as paramesonephric duct. Let's have a look at each of these various anomalies. This is the ASRM classification. You have various anomalies such as hypoplastic uterus, unicornuate, didelphys, bicornuate, septate, arcuate, and DES or diethyl stilbestrol related. In Mullerian agenesis, there is complete agenesis. Nothing is forming. No uterus, no fallopian tube, no cervix, even no upper vagina. What will be there? Ovary is present, lower vagina is present. Whereas in unicornuate uterus, you have partial agenesis, only one fallopian tube. Buzzword for you in the exam is one fallopian tube, one-sided uterus, and cervix. Again, cervix is present. Didelphys and bicornuate, it is fusion defect. And this was the question that came. Yes, unicornuate. Yes, unicornuate was the question that had come. Yes, unicornuate. All these are associated with Mullerian duct problems as such. Complete fusion defect is didelphys. Buzzword for you in the exam is, question gives you two cervix. It is didelphys. Whereas bicornuate, you have two uterine cavity, one cervix as such. Septate, you have a separation in between. It is a resorption defect. It is the most common anomaly among all the Mullerian anomaly is septate uterus. Most symptomatic anomaly is septate uterus. Next, you have a small indentation at fundus, that is arcuate, finally related to the drug diethyl stilbestrol. Yes. So all these are Mullerian anomalies as such. They are associated with defect in Mullerian duct, also known as the paramesonephric duct. Yes, this is another variation of the question which I again received from the students. They showed that this anomaly image was given in the question and they had asked about this. Yes, again the same answer, failure of fusion of the paramesonephric duct. Yes, development of paramesonephric duct. Let's have a look at the next question. Oral contraceptive pills are shown to provide protection against, it is not protection against which of the following cancers? Which cancer risk increases or which genital cancer risk increases with the use of OC pills? The cervical cancer. Yes, again from the risk factors of cervical cancer, we know that OC pills increases adenocarcinoma of cervix. Cervical cancer, there are two types, squamous cell cancer, which is most common type, even the adenocarcinoma, which is less common. Adenocarcinoma increases with the use of OC pills. Even the next risk factor that you have to know with adenocarcinoma of cervix is HPV-18 is associated as well. The protective factors of CA cervix or the contraception which is protective is condom or the barrier method as such. Condom or barrier method is protective. The cancers which are protected with the use of OC pills, it is remembered as CEO. What is CEO? C for colorectal cancer, E for endometrial cancer, O for ovarian cancer. Whereas cervical cancer risk increases with the use of OC pills. Let's have a look at the next question. This was from RH isoimmunization about fetal anemia. Which Doppler is used? Fetal anemia is best detected using Doppler of which arteries? Yes, again, the same question came in the last exam as well. Which artery is assessed? It is middle cerebral artery. Middle cerebral artery peak systolic velocity is assessed. Whenever you have a patient who is RH negative, isoimmunized, that means RH negative and ICT positive, these babies have high risk of developing fetal anemia. So the next test that you will do is ICT titer. If the titer is more than 1:16, we proceed with middle cerebral artery Doppler. If you see that RH negative, ICT is negative, that means she is non-sensitized. You proceed with, again, repeating the ICT. We keep on following up the patient with 4 weekly ICT. Yes, this is the algorithm, the whole algorithm for management of any RH negative pregnancy as such. Patient comes to you RH negative, you keep on repeating the ICT 4 weekly. At 28 weeks, you will give her first dose of anti-D. Again, after delivery, if you see that baby blood group is positive, you have to give the patient anti-D. ICT is positive at any point of time. Next test is ICT titer. ICT titer more than 1:16, your answer is middle cerebral artery Doppler. Yes. So in simple words, if I tell you RH negative, ICT negative or non-sensitized pregnancy, follow up with ICT. RH negative, ICT positive pregnancy or RH isoimmunized pregnancy, also known as RH sensitized pregnancy, who are at increased risk of developing fetal anemia, you proceed with middle cerebral artery Doppler. Yes, correct answer is middle cerebral artery Doppler. Let's have a look at the next question. A 32-year-old multigravida, history of previous 2 cesarean section is there. She presents with massive hemorrhage during cesarean section, and the placenta is found to be densely adherent to the uterus. What am I suspecting now? Placenta accreta spectrum, also known as PAS. Now it is shown that it is invading through the myometrium into the bladder walls. Now what is your diagnosis? This placenta accreta spectrum, I always say any patient comes to you, previous cesarean section, especially if they have placenta previa, have a high suspicion of PAS. If the placenta is not delivering, think about placenta accreta spectrum. There are 3 varieties. You have accreta, increta, percreta. Accreta means adherent. Increta means invading myometrium. Percreta is perforating myometrium. Where all it can go? It can perforate the myometrium, go outside towards the serosa. Next time question gives you serosa of uterus is involved. Your answer is percreta. Bladder is involved. Urethra is involved. Blood vessels are involved. Your answer is percreta. So in the option, you will see 2 options. Accreta, increta as well as percreta. All 3 are given. Yes. Among this, which one will you choose? Your correct answer is percreta because bladder is involved. If suppose nothing is there, they don't give increta or percreta, you can choose accreta because it comes in that spectrum of placenta accreta spectrum. Here, what is the best answer you are going to choose? It is placenta percreta. Yes, bladder wall is involved. Yes, let's have a look at the next question. What is the presenting diameter in phase presentation during the time of labor? Yes, phase presentation is there. What is the diameter? Yes, so depending on what the presentation is, the diameter changes. The most common one is fully flexed. When you have a fully flexed head, it is suboccipitobregmatic. This is the diameter. When you have fully extended one, face is presenting next to you. Then you have submentobregmatic. Yes, that was the question. Submentobregmatic is the one that you get in face. Whereas partial extension is mentovertical. The engaging diameter is broad. Your correct answer is submentobregmatic. SMB or submentobregmatic. Very good. Yes, that's the correct answer. Submentobregmatic. Answer is B. Let's move to the next question. During a vacuum-assisted delivery, the correct site of vacuum application is. What is the correct site for vacuum application so as to facilitate maximum flexion? We are going to apply it at flexion point. What is this flexion point? Yes, let me again show you from the class notes. This is the flexion point. What is flexion point? Flexion point is 3 centimeters anterior to posterior fontanelle. Flexion point is 3 centimeters anterior to the posterior fontanelle. So the midpoint of the vacuum cup should fall on this point as such. This is flexion point. So what is flexion point? It is anterior to posterior fontanelle. Ideally, some students were even telling they had given in centimeters. Can someone confirm in the comment section as well what the centimeters given? Yes, if so, the best answer is 3 centimeter anterior to posterior fontanelle. The flexion point 3 centimeter anterior to posterior fontanelle. Yes, anterior fontanelle. Posterior fontanelle. 3 centimeter anterior to posterior fontanelle. Not anterior fontanelle here. Yes, the posterior fontanelle. The triangular one that you see here, this is the posterior fontanelle. 3 centimeters anterior to the posterior fontanelle you will apply over here. That is the flexion point axis. Yes. Again, previously last year also there was one question on flexion point axis. This vacuum application, that forceps, the different types of forceps that are must know topics as such. When will you, the indications for applying any form of instruments, contraindication, all those are very important core areas as such. Apart from this, the pressure that is used for vacuum is nearly 600 millimeters of mercury. You apply the vacuum, if it pops off, you can give maximum 3 pulls. You apply, it pop off. Again, you apply, it pops off. How many pulls can you give? Maximum is 3 pulls like that. If still the baby is not delivered, the next step is going to be cesarean section. So if they give you this in a clinical scenario, 3 times you have applied it, still it has popped off, your management is going to be cesarean section. Yes, let's move to the next question. Fetal surface of the placenta receives its blood supply primarily from which of the following arteries? You know the placenta has a fetal surface as well as a maternal surface as well. This is the fetal surface, this is the maternal surface. The fetal surface of placenta arises from chorion frondosum, whereas the maternal surface arises from decidua binsalis. Yes, the maternal surface is receiving blood supply from spiral artery, which is a branch of uterine artery, whereas the fetal surface receives its blood supply from umbilical vessels. Yes, spiral artery, maternal surface, and the fetal surface is umbilical vessels. Yes, the correct answer is umbilical artery or umbilical vessels. Yes, let's go to the next question from induction of liver. Prior inducing the patient, we usually assess the PV so as to check the Bishop score. And in this question, they have asked you to calculate the Bishop score. What are the components of Bishop score? You are going to check 5 things. These 5 things are position, dilatation, effacement, station, and consistency. You can remember with the mnemonic pink desk as well. Position, dilatation, effacement, station, and consistency. In this question, the question is giving you the position is mid position. She is 2 centimeter dilated, 50% effaced, station -2, cervix is soft. What is the Bishop score? We can just add it up. Mid position gets a score of 1 each. Of these get a score of 1 each, and soft get a score of 2. So total score is 6. The complete score is 6 axis. I would say this box is a bit volatile. So mark it out, like keep it out for your volatile book or for your 20th book, whatever, so that you revise this box again and again in the final days prior to your exam. So this is the Bishop score. What about modified Bishop score? In modified Bishop score, this effacement is replaced with cervical length. Effacement is replaced with cervical length. Rest others are same. Position, dilation, cervical length, station, and finally consistency. Yes, finally consistency. About umbilical artery and umbilical vein, it is just opposite in the placenta access. Umbilical artery will carry the deoxygenated blood, whereas umbilical vein is the one that will carry the oxygenated blood. So this umbilical vein will carry the oxygenated blood towards the baby, and from there, the deoxygenated blood will be brought outside by the umbilical artery. So just opposite, you remember. And usually there are two arteries and one vein. Which vein is left behind? It is the left vein, which is left behind as such, whereas the right is going to regress. So umbilical cord will look something like this. You have two arteries and one vein, and it is usually the left vein. Arteries carry the deoxygenated blood. Vein will carry the oxygenated blood. In between, you have this jelly in between. That jelly is known as Wharton's jelly. You have this Wharton's jelly, which is actually protecting these umbilical blood vessels. All right. Let's have a look at the next question. The given image shows a surgical technique involving dissection of bladder and vaginal mucosa, followed by placement of this not non-absorbed, rather than suture. There is a tape-like structure which is shown in the image, and it is buried under the mucosa as well. What is shown over in this image? What is shown over here? Yes, option, ma'am, 6 was not in the option. Then this Bishop score as such will be slightly different. What will be given over in the question here? Let me take back the question. Yes. As it is a recollected question as such, these percentages, these values might be slightly different as such. You just have to remember this table, put in the exact values as it is there. It will give you the exact Bishop score. Yes, this is how we are going to even do this, even in the clinical practice as well. Every patient in labor or patient who comes to us, even for induction, we generally calculate a Bishop score by looking at all these parameters. You just have to memorize this box, put in the values, it will give you the exact Bishop score. If suppose anything was slightly different, like closed doors or something like that, it might shift a bit, depending on what is exactly given in the question. All right. And what is the type of cerclage that is shown over here? Some of the students were telling that it was a suture which is shown in the image. Some were telling that majority were saying this was the exact image that was given in the question, where you see a tape which is there around the cervix. And this is an image that has been taken from the Williams textbook itself. What you are seeing over here is a modified Shirodka cerclage. In Shirodka cerclage, instead of a suture, which is used in McDonald cerclage, we use a tape. We use a tape, we dissect the bladder, we push the bladder, you apply the stitch. That's the normal Shirodka. Without dissecting, you are applying is the simple Shirodka cerclage access. Yes, modified was given. Yes. So the next one is the normal McDonald cerclage. In McDonald cerclage, it's very easy to identify. You will not see the stitches like this, just not going around the cervix like this. In case of your McDonald, the stitches are going in a purse string manner. You will see this purse string sutures which is there, and it is suture which is going to be tied as such. Yes, it is the purse string sutures which is finally tied, and the final image will look something like this. This is the McDonald cerclage. McDonald is with sutures, whereas the Shirodka you are going to apply with the tape, muslin tape. Majority of the students had indeed told tape. Some of the students who are mentioning suture, it might be due to this image. Finally, after you put the tape as such, you are going to close this tape. Above this, you are going to just suture this mucosa around this by using suture. But predominantly, the cerclage is put with the tape as such. Yes, this is the Shirodka cerclage, which is shown over here. Yes, the same image. Majority of the students had sent me this image itself. Yes, this is your Shirodka cerclage. This is the Shirodkar cerclage. Let's move to the next question. This was from secondary amenorrhea. The algorithm of management of secondary amenorrhea question had come from this. Let's go through the question. A patient develops secondary amenorrhea following history of DNC. It's a buzzword for you. Question is giving you DNC. She has been given progesterone challenge test, estrogen plus progesterone challenge test. Still bleeding is not there. What is the likely diagnosis? Yes, all of you are correct. It is Asherman syndrome. How to identify or how to go ahead in a stepwise manner for any patient that comes to you with secondary amenorrhea. Suppose a patient comes to me for secondary amenorrhea, the first and foremost thing to rule out is pregnancy. You will do a urine pregnancy test. UPT is negative. In that scenario, we usually proceed with hormonal testing, that is TSH and prolactin. Majority of the time, this option is not given in the question. They proceed with then proceed with the next step. What is the next step? You give the patient progesterone. You give progesterone for 5 to 7 days. Wait for withdrawal bleeding. If you see that there is no bleeding with progesterone challenge test, you give estrogen plus progesterone challenge test. You give estrogen as well as progesterone. Still there is no bleeding means think about the problem at the level of endometrium or at the level of uterus. Endometrial defects such as Asherman syndrome. This is a very commonly asked typical question as such. Patient does not bleed despite giving progesterone, despite giving estrogen plus progesterone challenge test. Think about Asherman syndrome or endometrial defect, or even they can give you problem at the level of uterus. Suppose she bleeds after giving estrogen and progesterone, you will think about problems at the level of hypothalamus, pituitary or ovary. How to differentiate this? Ovarian problem, FSH is raised, estrogen is low, whereas hypothalamus and pituitary problem, FSH as well as estrogen is low. This is the complete management algorithm for any patient that comes to you with secondary amenorrhea. Again, in this table, in this whole algorithm, I would ask you to focus on two most important points. First and foremost, never forget UPT. Any patient with amenorrhea, first is UPT. Then if progesterone, estrogen, that is estrogen plus progesterone challenge test is negative, think about problem at the level of uterus, at the level of endometrium, such as Asherman syndrome. Yes. Again, in this question, as DNC is given, I hope majority of you, even if you don't know that estrogen, progesterone, even if you are just missed on that point as well, it is easier to come to that answer because of this point as such. Correct is Shirodkar, dear. Shirodkar. Yes, this tape, this is Shirodkar. This is the Shirodkar cerclage. And for an image-based question, it is very unlikely they will ask you to differentiate modified Shirodkar as well as Shirodkar. Because in that, it is a small surgical technique as such, which is different between both this. In Shirodkar, you dissect the bladder and you will push the bladder as such. If the question shows you that image where that bladder is pushed as well, that is going to be Shirodkar. Whereas it is not pushed, it is going to be modified Shirodkar. I don't think they will go to that extent as such in this exam where they ask you between modified Shirodkar and Shirodkar. Was that given in the option? If so, as shown in the image like this, where the pushing of bladder is not there, then the answer is going to be modified Shirodkar. Whereas if they show you that image, even when the bladder is pushed as well, that is going to be your simple Shirodkar cerclage. Yes. What I heard is the same image was there, right? Yes, I got it from same image. What I heard from majority of the students were options were McDonald, modified McDonald, and Shirodkar cerclage, and something else was there. If at all they had given this modified as well as Shirodkar in this image, it is the modified Shirodkar cerclage, which is shown over here. Less likely, I don't think those two options were there. Yes, if so, if at all you're saying that if that option was there, it is modified Shirodkar. Yes. And yes, modified Shirodkar. Yes, this is an exact image from Williams' textbook as is the same image. I think the same thing they had given us. You can read from that as well. Yes, no doubt in this. This is because the bladder is not pushed. Both Shirodkar, simple way to differentiate. Your McDonald, you are going to see the sutures. Shirodkar, you are going to see the tape. The Mercelin tape you are going to see. Mercelin tape, with that you have pushed the bladder, dissected the bladder, that is going to be your normal Shirodkar, whereas in the modification, you don't dissect and push the bladder, such as in this image. Yes, this is the modified Shirodkar cerclage. Yes. Okay. So in this option, among the option which I got, the modified was not there. If at all that option is there, your best answer is modified Shirodka cerclage. Worm cerclage. Yes, one option which I got was worm cerclage, where you will take these parallel sutures like this. This is the worm cerclage. Worm cerclage is a type of emergency cerclage. Patient comes to you with dilated cervix. You have to do an emergency cerclage. You can go ahead with worms cerclage. Okay, moving to the next question. A 28-year-old primigravida, 41 weeks of gestation, presents in labor. On examination, uterus appears tonically contracted. There is a transverse groove which is felt and visible above the abdomen, just above the pubic symphysis. Baby's head or fetal head is not descending despite good uterine contraction. What is this groove that you feel between the upper segment and the lower segment when the labor is not progressing well, especially in obstructed labor? Especially in obstructed labor, you can get this groove between upper and lower segment. This can be felt, even palpable as well. This is the pathological retraction ring, which is known as Bandel's ring. Pathological retraction ring, also known as Bandel's ring, it is often associated with obstructed labor. Again, obstructed labor, they often ask you what is the management you are going to do for such patients. Management is cesarean section. Yes, management is going to be cesarean section. What happens? The upper segment keeps on contracting, it becomes thicker, whereas the lower segment is becoming more and more thinner. In between, you feel this groove. If it keeps on progressing, the patient can have uterine rupture, even postpartum hemorrhage. As a long-term complication, there can be vesico-vaginal fistula as well. Yes, this ring which you are seeing, this is basically the ring which you feel between this upper and lower segment, which is palpable as well. That is the pathological ring or the pathological retraction ring, which is known as the Bandel's ring, which is present in this. Yes, I think there is slight lag between the question and this thing, because I'm getting some question from the progesterone withdrawal test. Yes, from the previous question. Yes. Ma'am, progesterone withdrawal challenge test is positive means. Yes. What does progesterone withdrawal test positive means? I'm taking few seconds to go back to the question because there is a query on this. If progesterone withdrawal test is positive, that means the patient is responding to progesterone and she is bleeding with that. That means ovulation is not happening in the patient, such as causes of anovulation, such as PCOD, is associated with positive progesterone challenge test. Whereas negative progesterone challenge test, I will think about problem at the level of hypothalamus, pituitary, ovary, or uterus. How to differentiate? You will go ahead with estrogen plus progesterone challenge test. Yes, we have discussed the rest of the scenario. All right. Moving to the next question. A 16-year-old individual is brought for evaluation of primary amenorrhea. She has very well developed breast. Tanner stage 4 breast is there. There is sparse pubic hair as well as axillary hair. This girl was raised, the person was raised as a girl, but the karyotype reveals that karyotype is 46XY. Very well developed breast. There is no pubic hair, axillary hair. 46XY. What are you thinking about? All these are buzzwords. This is pointing towards androgen insensitivity syndrome. What about your MRKH, Turner's, or even Swyer syndrome? Let's differentiate between this. Yes, again, this is a box which is differentiating all these three scenarios. AIS as well as your Swyer syndrome. Both of this, the karyotype is 46XY. Both of them, the gonads are going to be testis. You see that Swyer syndrome, the buzzword for you in the exam is uterus is present. Uterus is present in case of Swyer syndrome, whereas uterus is absent both in MRKH as well as your androgen insensitivity. Buzzword for you for the androgen insensitivity syndrome is very well developed breast, absence of pubic and axillary hair. MRKH is a female as such, only Mullerian duct is absent. So she will be having pubic hair, she will be having breast development, even the gonad is ovary. How to manage this condition? Swyer syndrome, the risk of cancer developing in the gonad is very high. You have to do gonadectomy as soon as possible. Is there any need for vaginoplasty? No, they already have uterus, they already have vagina, no point of vaginoplasty. Whereas both MRKH as well as androgen insensitivity syndrome will benefit from vaginoplasty. Previous year question, when do you do vaginoplasty? Usually we do this prior to sexual activity or prior to the marriage as such. Again, in androgen insensitivity also we do gonadectomy. When is gonadectomy done? Gonadectomy is done after puberty or after secondary sexual characters are complete. We want the ovaries to produce the hormones which will induce this secondary sexual character development. So gonadectomy is done after the puberty as such. Yes, so this is yet again a very, very important box as such, differentiating these three clinical scenarios. Yes, have a note of this. Turner's. What about Turner's? In Turner's syndrome, the key features will be you will have a short patient. The karyotype is going to be 45XO. You have the classical stigmata of Turner's syndrome, such as webbing of neck, low posterior hairline, cubitus valgus deformity. You will see that everything is chota chota. Yes, the ovaries are chota, streak ovaries. Uterus is also chota, hypoplastic uterus. Patient is also short. Even you will see that there is poorly developed breast, widely spaced nipple, and poorly developed breast. What about intelligence in this patient? Turner's IQ is normal. They have normal IQ or normal intelligence as. Again, all these features are going against Turner's syndrome. Turner's, the hair growth is present. The karyotype is not 46XY. So again, the answer is not Turner's. This is typically androgen insensitivity. They can give you any of these scenarios. Okay, all these scenarios are very important. They will give you a question. Even if they give you rarer options, you can easily come to the answer by ruling out these very common options or questions as such. Yes. Apart from this, from the topic of amenorrhea, have a note of that bulging bluish membrane, which is seen in imperforate hymen. Yes, this was the second question that we talked about from screening. Yes, what is the ideal fixative that is used for pap smear? It is 95% ethanol is the fixative that you use. Yes, again, directly from screening as such. Let's have a look at this scenario. A patient has come to you with history of cesarean section and there is fresh bleeding from the vagina with sudden onset of abdominal pain. What is the diagnosis in this scenario? Patient has previous cesarean section, sudden acute onset of abdominal pain is there, vaginal bleeding is there. This is typical. What are we afraid of? In every cesarean patients who go ahead with TOLAC, trial of labor after cesarean, there is chance of rupture of uterus. Yes, uterine rupture. So uterine rupture, all the layer of uterus is disrupted. So you have hypotension, you have sudden stoppage of contraction, patient can have pain. The fetal parts are easily palpable as such. Baby comes out into the uterine cavity, the fetal parts become very easily palpable. Whereas in case of abruption, fetal parts are not easily palpable. Even in this scenario, if they have not given you that fetal parts palpable or not, still you will go ahead with uterine rupture because question is giving you sudden pain, previous history of cesarean. Yes, previous cesarean, sudden pain, vaginal bleeding is there. It is more pointing towards uterine rupture. Even they can give you a scenario on uterine dehiscence. Dehiscence is that stage just before uterine rupture. What happens in uterine dehiscence? These layers are disrupted but partially. As there is partial disruption, you will have the patient starts developing tachycardia. You will note that there is scar tenderness. Even there can be vaginal bleeding and hematuria. Uterine dehiscence, the management is cesarean section, uterine rupture. Immediately go ahead with laparotomy. You will do a laparotomy. You are going to take out the fetus. If the repair is possible, you repair it. If repair is not possible, you might even have to do a hysterectomy for the patient. So if repair is not possible, you might even have to proceed with hysterectomy for the patient. Yes, let's move to the next question. Females often experience recurrent urinary tract infection, but rarely it leads to the vaginal infection despite the close proximity to the anal opening and vaginal opening. Which of the following best explains the natural protective mechanism of vagina against infections? What is the most important vaginal mechanism as such to prevent against infection? We see that in the vagina, you have this acidic pH, which prevents majority of the infections as such. And this acidic pH is due to conversion of glycogen into lactic acid by Dordaline bacilli. And this conversion is facilitated by estrogen. Though that is why we see that in reproductive age group where estrogen is there, the pH is acidic in nature. Whereas when you look at women who are either in their menopausal age group or at the time before puberty, prior to puberty, or even in menopausal, the pH will be slightly alkaline, more than 7. Yes. So here we are dealing with reproductive age group. Estrogen is a protective mechanism. It facilitates the conversion of this glycogen to lactic acid, maintaining the acidic pH of the vagina. So acidic pH is basically promoted by the presence of high levels of estrogen, which again prevents the infection, and it also promotes the mucus secretion as such. Let's move to the next question. A 12-year-old female has developed breast buds, Tanner stage 2, and there is appearance of pubic hair, again Tanner stage 2. What is the next expected milestone? Yes, what is the order of puberty? Let's discuss this from the chapter of puberty. First and foremost thing that happens is increase in growth, which is known as growth spurt. Followed by growth spurt, you can remember the Prime Minister. The Prime Minister, yes. D is for thelarchy, P for pubarchy, next comes menarche. So thelarchy is the development of breast, pubarchy is the development of pubic hair, menarche is the development of menstruation. So first sign that appears is growth spurt. First visible sign is going to be thelarchy. In between pubarchy and menarche, you have peak growth velocity. Usually we say, once puberty is reached, once the menstruation happens, then the girls do not grow that much as such. Usually the maximum growth happens before the onset of menstruation. Once the menstruation starts, the growth usually stops as such in female. So the peak growth velocity happens before menarche. Yes, before menarche. What is the next milestone that you expect? It is peak growth velocity or the peak height velocity. Finally, there is menarche. If pre-growth velocity was not in the option, then your answer would have been menarche as such. Your correct answer is peak growth velocity. Let's briefly go through the hormone which is responsible for each of this. Thelarchy is under influence of estrogen, whereas the pubic hair, all the hair growth is under influence of androgen. Again, this concept was even asked in this exam. Menarche is due to both estrogen as well as progesterone hormone. Yes, growth spurt is the sudden increase in the growth beard. Initially, you get growth spurt. Growth spurt. Yes, first you get that sudden increase in growth, that is the growth spurt. Then the thelarchy, development of breast. Next you have pubarchy. Then next you have peak growth velocity. Maximum increase in growth of the patients. Finally, menarche or menstruation. Yes, that's the answer to your question here. Yes, let's move to the next question from perineal tear. So they had given this perineal tear where the tear is involving less than 50% of the external anal sphincter. No involvement of internal anal sphincter or rectal mucosa. What is the degree of tear as such? Yes, these are the various degrees of tear that we discuss. First degree, vaginal mucosa, perineal skin. Second degree, perineal muscles are involved. Third degree, anal sphincter is involved. Fourth degree, anal mucosa is involved. Third degree is further subdivided. 3A means less than 50% of external anal sphincter. 3B means more than or equal to 50% of external anal sphincter. And 3C means internal anal sphincter. What is given in this question? They had given you less than 50% of external anal sphincter. So what is the answer here? It is 3A. Yes, the correct answer is 3A. 3B will be the answer here if they give you more than or equal to 50% of external anal sphincter. Question here gives less than 50% means it is going to be 3A. More than or equal to 50% is 3B, whereas internal anal sphincter is going to be 3C. Yes. Let's move to the next question on endometriosis. A patient has presented to you, 36-year-old. She is para to living to with endometriosis and she has multiple surgeries in the past, multiple treatments as such in the past. She is in severe pelvic pain. You know, the most common symptom of endometriosis is pain. Patient complains of pain such as dysmenorrhea, dyspareunia, chronic pelvic pain, followed by infertility and even ethnic cell mass. So this patient, family is already completed and she wants definitive management as such. What is the most appropriate management for this patient? For the management of endometriosis, these are the various options. One is expectant management. That means do nothing for the patient. You are just going to leave her. If she is asymptomatic, if she is postmenopausal, you can leave the patient. Whereas if you see that the patient has symptom, you start with the simplest measure. What is the first line treatment that we give for the patient? We start with NSAIDs. If that treatment is not working, we go ahead with OC pills, progesterone. If still not working, we have options like GnRH agonist. Especially if a patient wants contraception, you are going to proceed with OC pills. Danazol is not commonly given because it is associated with androgenic side effects such as acne, hirsutism. Next comes surgical management. Surgery, we have cystectomy, adhesiolysis, ablation, depending on the condition. Question gives you endometriotic cyst, go for cystectomy if it is more than 4 centimeter. Question gives you adhesions are there in the surgery, you go for adhesiolysis. If there are deposits, you ablate the deposit. But what is the definitive management? The definitive management or the last line, after last resort of everything fails, she wants something definitive, it is going to be hysterectomy, bilateral, salpingo, oophorectomy. We don't commonly do that. Okay, we very rarely go ahead with this surgery, but afterwards, as a last resort, as a final thing, we can go ahead with TAH and BSO, such as in this question. His answer is TAH plus BSO for the patient. Let's move to the next question. In this question, they had asked about the MEC1 for OC pills use, medical eligibility criteria. So the medical eligibility criteria, MEC1 means there is no contraindication at all. You can use the method in any circumstances. MEC2 means the advantages outweigh the risk. MEC3 means do not use, and you can generally we do not use, the risk outweigh. MEC4 completely not use. So basically they are asking you in simple words, which among the following is not a contraindication for giving OC pills? Which among the following is not a contraindication as such among this? These are the contraindication of OC pills that we discussed. A very important contraindication is thromboembolism. Apart from this, diabetes, which is associated with vasculopathy, hypertension, which is severe, dyslipidemia, which is severe, are contraindication as given in this question. You will see that HIV is not a contraindication as such for OC pills. Yes, HIV can be, even patients with HIV can use this OC pills you can still use that. Migraine with aura, smoker who is more than 35 years, patient who has liver dysfunction. These OC pills, again, they are metabolized through the liver. Patient has marked liver impairment, you are not going to use that. Cancer of breast cancer is there. Any estrogen dependent cancer is there, you will not give OC pills. Patient with undiagnosed bleeding, despite if you don't evaluate the patient, you will not give any form of hormonal treatment if the patient is not evaluated. Any undiagnosed bleeding, stay away from any form of hormonal tablets. It can be hormonal tablets, hormonal implants, or maybe IUCDs, that is like Mirena, all type of hormonal management. You have to confirm that what type of bleeding it is. If it is an undiagnosed abnormal bleeding, you will not give them. Peripartum cardiomyopathy as well, it's a contraindication. So among this, which among the following is not a contraindication where you can use this? It is HIV. Severe diabetes, severe hypertension, severe dyslipidemia, especially diabetes with vasculopathy, are not going to use OC pills. In all these scenarios, we usually prefer IUCDs, yes, intrauterine contraceptive devices. Again, another question from contraception as such, which among the following is an absolute contraindication for subcutaneous contraceptive implants? Which among the following is not, in each of the following condition, will you not use an implant as such? In the options, again, you will see implants, again, they have these hormones as such. You are not going to give them for undiagnosed genital bleeding. Let's have a look at the contraindication for implant. For any form of implants or even progesterone only contraceptives, the contraindication are similar. Any patient who is pregnant, you will not give this. Any patient who is using enzyme inducing drugs, you are not going to give for the patient. Patient with liver disease, breast cancer, and unexplained vaginal bleeding. Among this, unexplained vaginal bleeding is very, very, very important. Patient has unexplained vaginal bleeding, stay clear of all these hormonal methods. Even for IUCDs as well, you don't insert it unless until you find out what is the cause. Unexplained, undiagnosed vaginal bleeding is again a contraindication. Let's have a look at this next question. Which among the following is true regarding the evaluation of endometrial hyperplasia? Patient has endometrial hyperplasia. What will you do for the patient? If you see a thickened endometrium, you are going to go ahead with endometrial sampling. The methods of endometrial sampling are given over here. We have Fetal biopsy. You can proceed with DNC. You can take biopsy with Karman's cannula, or even fractional curettage can be done. But what is the gold standard? Gold standard is to see and take a biopsy. The gold standard investigation or the best investigation is going to be hysteroscopy plus biopsy. The gold standard investigation is definitely hysteroscopy and biopsy. Let's go through all the options one by one. Endometrial thickness less than 5 millimeter always rules out endometrial hyperplasia. Patients who have endometrial thickness more than 5 centimeter, we have more suspicion assets. Even if less than 5 millimeter is there, we cannot, more than 5 millimeter, more than or equal to 5 millimeter, more pointing towards hyperplasia and possibility for cancer. That's why we take the biopsy. But still, even in patient less than 5 millimeter as well, there is possibility of endometrial cancer, especially this type 2 type of endometrial cancer. Type 2 endometrial cancer can happen even in atrophic endometrium assets. Endometrial aspiration is the gold standard for diagnosis. Aspiration is good, but the gold standard as such is going to be the hysteroscopy followed by biopsy. Preferred method is always endometrial biopsy. It can be by aspiration, such as Fetal biopsy, which is preferred, but it's not the gold standard. Gold standard or the best one, as we discussed, is going to be hysteroscopy plus biopsy. Endometrial hyperplasia will never progress towards cancer. Absolutely wrong. There is higher risk of progression towards cancer, especially if you have endometrial hyperplasia associated with atypia. What is the risk of cancer? Risk of cancer is 25 to 33%. If you remember one value, you can remember it as 30% as well. Endometrial hyperplasia without atypia. Without atypia, the risk of cancer is less than 5%. So anyway, risk of cancer is there. That is why usually endometrial hyperplasia with atypia, what is the definitive management? The definitive management is to take out the uterus, hysterectomy. Yes, again, a very important, very favorite question. What do you do for endometrial hyperplasia without atypia? We give the patient progesterone. You can give progesterone such as Mirena, levonorgestrel containing intrauterine system can be given for the patient. Yes, let's have a look at the next question. Diagram of the mammary gland was given highlighting the ductal structures, the ducts which is there within the breast. Which hormone is primarily responsible for this? You know, in the breast as such, you have the SNI, also known as alveoli, and the duct. The duct proliferation is mainly under influence of estrogen. You can remember D and E. Duct is under influence of estrogen, whereas SNI or alveoli is under influence of progesterone as well as estrogen. In both of these, estrogen is common. If duct alone is asked, the predominant hormone is estrogen. If alveoli is asked, it is progesterone along with estrogen. For alveoli, if you have to choose one hormone, it is going to be progesterone. For duct, if you have to choose one hormone, it is going to be estrogen. Yes. Again, also we see that in the breast, the fat tissue as well increases. Fat increase is under influence of insulin. Yes. So you can remember the duct is estrogen and SNI is progesterone as well as estrogen. So here the duct proliferation is mainly under influence of estrogen. Yes, duct is mainly under influence of estrogen. Let's have a look at this next question on missed abortion. So in the types of abortion, you have various types of abortion such as threatened, inevitable, incomplete, complete, and missed abortion. What is this missed abortion? Missed abortion, basically, you have this dead fetus. The baby has died very early in the pregnancy. So the fetus is retained within the uterus with no signs of expulsion. What will you get in that? When we do the ultrasound, we can either get a big gestational sac. Gestational sac more than or equal to 25 millimeter with no fetal pole. Yes, more than or equal to 25 millimeter with no fetal pole. Or you can get a fetal pole more than or equal to 7 millimeter with no fetal cardiac activity. or once the fetal cardiac activity was there, it has disappeared. Any one of this is there, you will make a diagnosis of missed abortion. The first scenario where gestational sac is more than or equal to 25 millimeter with no fetal port, this is also known as blighted ovum. Yes. What is this scenario that we are dealing here? Which among the following is missed abortion? Gestational sac, no fetal cardiac activity at crown drum length of more than or equal to 7 millimeter. Whereas if gestational sac was given, it should have been more than or equal to 25 millimeter with no fetal port. Yes, correct answer is A. CRL more than or equal to 7 millimeter with no fetal cardiac activity. Yes, that's the correct answer here. About the other types of abortions, again, question might come from this. Threatened abortion, you will see that there is bleeding in the patient, but rest everything is okay. The os is closed, the size of uterus is normal. Whereas in inevitable abortion, you will notice that the os is open, the products have not been expelled till now. So the size of uterus is again corresponding to period of gestation. Incomplete abortion, already patient has history of passage of clots or products, as something has already gone out, size of uterus is less than the period of gestation and os will be open. Complete abortion, everything is already expelled, all the products have gone out, so size of uterus come back to normal and os will be closed. So this is how you differentiate. They can give you 1 or 2 points from this to differentiate this as well. Again, a very important potential question. Which of the following physiological process is not primarily regulated by estrogen? Among this, which hormone is not, which of the following changes is not under influence of estrogen as such? Breast development is indeed under influence of estrogen. Even closure of epiphyseal plate is under influence of estrogen. Ovulation, you know, even indirectly, yes, estrogen is involved in it. Directly, it is LH as such. But yes, indirectly, yes. What about hair growth? Hair growth is predominantly by androgen. Before ovulation, the small follicles starts producing estrogen, that is the granulosa cells of follicles, and estrogen is the main facilitator that will increase the level of LH, and this LH will finally lead to ovulation. So indirectly, yes, even ovulation is indirectly influenced by estrogen. You know, there is need for estrogen in high sustained level, more than 200 for a period of 48 hours for the LH surge and LH peak to happen. So again, estrogen has a supportive role just before the LH surge. So even indirectly that is true, but hair growth is predominantly due to androgen. As we saw, menarche, estrogen plus progesterone, pubarche or any form of hair growth was under influence of androgen. Thelarche, breast development was under influence of estrogen. Again, this is indirectly from that concept itself. Hair growth is due to androgens. That is the correct answer for this. Ma'am, your revision notes helped me a lot for this case. Even the FTR, the fast track revision, had a very high strike rate as such. I'm very glad that all of you found OBG as a very strong subject. This time, like majority, it was, you could answer many of the questions and much of the predicted topics as such had come up. I hope all of you did wonderfully well in the exam. And so many questions were there. Some of the students had messaged me after the exam as well. Any doubts or questions we can take, or else we will wind up the session. I know you have been having continuous recall sessions one after the other in DocTutorials. So do go through that, especially for the upcoming batch who is there. You have to go through all these questions, that discussion. We see so many times these areas do get repeated. The question need not get directly repeated, but of course the areas get repeated. And I'm very happy that majority of you could attempt the ObGyn questions very easily. Yes, I heard that some of the wordings were slightly difficult or confusing as well. Yes. So how to overcome that? Practice more and more questions. Yes, more you do, you get that speed with practicing questions and everything. So if no further question is there, let's call it a day. Okay, yes. So we'll wind up the question. Any doubts or questions, you can directly message me as well. My Insta ID is obg_with_Gayatri. Yes, you can connect with me anytime. You can ask queries or messages in this aspect. Yes. So that's all. Thank you. Hello? Yeah, thank you, Vinod. Oh, thank you. But student parts, yeah.
No, they are watching up.